Good evening, everybody, and very welcome to this session of the UP AROI chapter teaching series for postgraduate students. And it's my pleasure to introduce Dr. Lavanya to you, who's an associate professor in the Department of Radiation Oncology at the Tata Memorial Hospital, Mumbai, where I think she's served for almost 8 years, perhaps. And she's a postgraduate from the Kidwai Memorial Institute of Oncology, and and is a part of the gynae disease management group. So, Dr. Lavanya, we look forward to listening your thoughts on different facets. The stage is all yours. Thank you.
Thank you so much, sir, for the introduction and for having given me an opportunity to present here. So the topic given to me is what I understood was the evidence of chemotherapy in the different settings of cervical cancer management. So before going into details of the management per se, all students are expected to understand and know the latest FIGO 2018 staging, with the where there is an introduction of stage 1B3, which was initially stage 1B2, with respect to the tumor size. Another important feature which was not there in the previous FIGO staging is the introduction of lymph nodal staging, and lymph nodes being assigned as stage 3C1 and 3C2 depending upon the pelvic lymph node positivity and parietic lymph node positivity. So why this is important is because the management changes with the management has to be more robust, and it is important for us to treat patients accordingly, as opposed to the previous staging where there was a relaxation and it was an optional thing. So another important feature that has to be remembered other than the tumor size is the pelvic lymph nodal involvement, which is an important prognostic factor, and the introduction of combined modality is based on the lymph nodal positivity in early stage cancers, whereas as you see in this slide, you can see that with the increasing stages, the lymph nodal positivity increases drastically, which is approximately 5% in 1A2, which goes up to 45% in stage 3 and above. At the same time, with the increasing stage, the positivity of parietic lymph nodes also increases, with almost less than 1% in 1A2 stage to 30% in stage 3. So that means to say it is our primary domain to treat this locally advanced cervical cancer patients, and it is important to know what are the combined modalities and where and how to apply these modalities. So the flow of the seminar would be that I would be presenting the evidence of concurrent chemoirradiation over the past 3 decades, and the use of neoadjuvant chemotherapy, basically the indications and the present evidence for the same, the use of extended field RT and the evidence supporting the same, because there are 2 subsets here, where it would be either prophylactic extended field prophylactic parietic irradiation and irradiation to the macroscopic parietic lymph nodes. If time permits, I would also touch upon the issue of pregnancy in cervical cancer. So this is an important slide. So it is important to know the indications, the advantages and disadvantages of chemotherapy when used in different settings. So we all know that when used in the concurrent setting, we're looking at the cytotoxic anti-proliferative effects and also some modest improvement in the systemic control. And also it inhibits the repair of sublethal damage from the radiation effects. In addition, the radiosensitizing effects and the hypoxic sensitizer effects in large primary tumors are exploited when we give concurrent chemotherapy in locally advanced cervical cancer patients. The downside is that with any combined modality, there is increased toxicities in this group of patients. When we talk of neoadjuvant chemotherapy, it is systemic chemotherapy. So like in other sites, it is aimed at elimination of micrometastasis and shrinkage of the primary tumor bulk, mainly to achieve operability. The disadvantages here are that it may select out the resistant clones, and it also delays the definitive therapy, that is radiotherapy. So adjuvant chemotherapy is given in case of residual microscopic disease. There is no evidence. I will be talking about the evidence in locally advanced cervical cancer later, but then the adjuvant therapy as of today is only for post-operative cervical cancer patients with positive margins, and pelvic lymph node positivity and parametral invasion. Again, here what you all have to understand is that the downsides of combined modality treatment, be it chemoradiation or surgery followed by chemoradiation, we expect higher toxicities for this group of patients. So this is a statement which says that all locally advanced cervical cancer patients eligible for chemotherapy, that is, who are fit for chemotherapy, should receive concurrent chemoradiation. So how did we arrive at this conclusion? I will be talking about in the further slides. So this is the evolution of chemoradiation cervical cancer, which almost started almost 3 decades ago, and the conclusion that we have arrived at depends upon all these individual trials in the later meta-analysis and the IPD meta-analysis, and further our own trials done in our country, and there are few trials whose results are still awaited. So this was one of the first initial trials which tried to evaluate the role of chemoradiation with 2 different drugs. This was in which patients were randomized into 3 groups, wherein the first group received only radiation, and the second group received radiation with weekly cisplatinum, and the third group received radiation with twice weekly cisplatinum. So what was observed? This study actually did fail to show any benefit in the long term. But initially, what was observed was that there is central control. The definitions was quite different 30 years back as compared to what we call as local control. So this was basically local control was better in patients who received cisplatin twice weekly. But this trial failed to show cisplatinum as a radiation potentiator, and there was no significant improvement in the long-term survival. So another important trial is, this is one of the first important trials, so which is the Whitney trial, which also constitutes one of the big 5 trials. So wherein the investigators tried to address the optimum chemotherapy regimen along with radiation. So here patients, one group received 5-fluorouracil and cisplatinum along with radiation, and the second group received hydroxyurea with radiation. So there were heterogeneous radiation doses at that time, and the treatment time was approximately 10 weeks. I'll tell you why this is important later. So what was observed is that the patients who received cisplatinum and 5-FU along with radiation fared better with respect to disease-free survival and overall survival as compared to patients who received hydroxyurea. At the same time, the patients who received the hydroxyurea had higher hematological toxicities, grade 3 and grade 4 toxicities, as compared to this doublet regimen. So what the criticisms or the reflections from the study is that they compared 2 chemoradiation arms. There was no radiation therapy alone arm. So the benefit of chemotherapy with radiation versus radiation alone was not answered. And like I mentioned, there was suboptimal radiation doses along with some heterogeneity, with many of the patients not receiving brachytherapy, especially in stage 3 and stage 4, and also with the protracted RT regimen, which was prolonged to 10 weeks. The overall treatment time was long. So here also the most common site of recurrences were in the pelvis, followed by distant metastasis in both the groups. So the next trial is by Rose et al. This is the second of the big 5 trials, wherein again patients were randomized to single agent cisplatin along with radiation, and an aggressive chemotherapy, wherein they tried to address if adding hydroxyurea to this doublet of 5-FU and cisplatin had more benefit as compared to the doublet. And again, this trial also had one arm of hydroxyurea. The students have to remember that these were the drugs that were available at that time and were being in research in for multiple solid malignancies. So I'll not go into the details of the dosages. So what was observed is that patients who received radiation along with single agent cisplatin, or patients who received cisplatin and 5-FU and hydroxyurea, their outcomes were much better as compared to patients with the hydroxyurea. So first take home message is that hydroxyurea went out, or it is, we understand that this is an inferior regimen as compared to platinum based radiotherapy regimens. So but what was observed later on is that the toxicity profile of patients who received triplet regimen as compared to cisplatin with similar outcomes had higher rates of hematological toxicities. And hydroxyurea, as told in the as I told in the previous trial also, there were higher toxicities. So the downside of this triplet regimen was that there was a higher toxicity rate with almost similar control rates. So then this made a case towards the use of single agent cisplatin. This is the update of the trial, which was published in 2007. So again, here you see that it is maintained. It is maintained that the use of platinum definitely improves the progression-free survival and the overall survival as compared to the use of hydroxyurea, which was maintained even at 10 years. So these are the Kaplan-Meier curves, where there is a clear gap between these two regimens. And this is for the stage 3 patient. This is the overall survival by the treatment for all patients. So even in stage 3, it was seen that there was a benefit of adding chemotherapy. So the next trial is, this is mainly a preoperative regimen. So what we call it as neoadjuvant chemotherapy or neoadjuvant therapy. This was called as preoperative treatment, wherein patients were randomized to preoperative radiotherapy. Preoperative radiotherapy versus preoperative chemoradiotherapy. Here, a single agent cisplatin was used. Here again, what was seen is that the use of chemotherapy, again, it had better survival rates with respect to progression-free survival and also overall survival in both these groups, which was statistically significant. Like suggested before, combined modality patients had higher toxicity rates as compared to radiation alone. So the criticism of this trial is that, again, it is suboptimal doses because it is in the preoperative setting, and only stage 1B patients have been included here. So these results cannot be generalized to the concurrent chemoradiation settings. So now we spoke about the preoperative setting. The Peters trial, I think all of you must be aware of Peters trial now. This was a trial which try to evaluate the importance or try to evaluate the role of adjuvant chemoradiation as opposed to radiation only. So here again, what was seen is that because these patients would have positive lymph nodal positivity post-operatively, and there was no consensus then also of whether to treat the parietic lymph nodes or not. So both the groups patients were treated with were treated for pelvis as well as the parietic lymph nodes. So here the chemotherapy regimen was cisplatin and 5-FU, where 4 cycles were given along with radiation. This is a trial which clearly showed the importance of adjuvant chemoradiation. So like you see that the PFS and the OS, there was a significant benefit, almost in the range of 15 to 17% with a statistical significance. And also there was an improvement in the distant failure rates with the use of cisplatin. So that means to say that there is some benefit of chemotherapy in the systemic control, even when used with radiation. So with this, the students have to remember that the Peters criteria are important for choosing patients for concurrent chemoradiation in the postoperative settings. So these there are, if you remember, PS, PQ, so positive margins, parametral invasion, and positive lymph nodes. So this is what it is. So now what was the next trial was the Morris trial. So what they did was, this is the a trial which tried to address which tried to evaluate the role of EFRT versus pelvic RT with chemotherapy. So in patients with only pelvic lymph nodes without parietic lymph nodes, what was hypothesized is that if at all EFRT can replace the use of concurrent chemoradiation limited to the pelvis or otherwise. So what was done is patients were randomized to pelvic EBRT and brachytherapy along with 5-fluorouracil and cisplatin versus patients versus EFRT, that is prophylactic EFRT was given to this group of patients. So what was seen here is that there was the patients who received CTRT to the pelvis only in patients who had negative parietic lymph nodes. So it fared much better as compared to patients who received EFRT. This has to be kept borne in mind. That means to say that prophylactic. This is again making a case that maybe prophylactic parietic lymph nodal irradiation is not required in microscopic disease. So DFS at 5 years was 67% for patients who received CTRT, whereas it was 40% for patients who received RT alone, but with the introduction of parietic lymph nodal irradiation. So I'll not go into the nitty-gritties of the doses of cisplatin and 5-FU used because you'll get confused with that. So the when this again it was updated, the long-term efficacy again it was seen that the combined modality treatment definitely fares better even at an extended follow-up times as compared to radiation therapy alone. So when you look at the toxicities of these two trials, you see that the late toxicities are almost similar in both the arms, but the absolute number of events are different depending upon the modalities. So when the subgroup analysis was done in the SATI-OG trial, what was observed is that the stage 1 and stage 2 patients had a higher benefit of when they received chemotherapy as compared to patients in stages 3 and 4. But it has to be remembered that the stages 3 and 4 where the numbers were smaller as compared to the stage 1 and 2. So we cannot really deduce generalizable results here. So out of the big 5 trials, this is one negative trial, whereas in this trial, they had randomized patients to concurrent chemoradiation with single agent cisplatin versus radiation therapy alone. So what was observed is that there was no significant difference in the progression-free survival nor in the overall survival. So possible explanations for this would be that this is a very small RCT and it was underpowered to detect a difference less than 15%. And it was also observed in this study, reasons unknown, there was a higher decrease in the hemoglobin in the CTRT arm in this trial. So these are the main trials that have to be remembered, which I've briefly spoken about till now. So in all these trials, what can be seen is that the use of chemotherapy has a benefit as compared to the use of radiation therapy alone in locally advanced cervical cancer patients. But like I said, there were pre-op trials, there were post-op trials, and there was not a head-on comparison of radiation versus chemoradiation. So these are some of the trials. But like you see, these are the trials wherein chemoradiation has been compared to radiation. But you see, the Eiffel study was basically EFRT, extended field radiotherapy, in an era where we did not have conformal techniques, which was compared to systemic chemotherapy with doublet, which again cannot be followed in the present day, nor can be compared to the KEYS trial. In addition, the Peters trial was used in the post-operative setting, so it cannot be used for locally advanced cervical cancer patients. And POC study was used in LACC patients, but again, like I said, this was a negative trial. So these the other trials, Whitney and Rose, basically try to identify the best chemotherapy regimen, assuming that chemotherapy is important. So these are the positive trials and these are the negative trials. So what you observe is that the difference is there only in the control arms. Whereas patients who received chemoradiation, their outcomes have been similar across the trials. And also we identified, or the importance of overall treatment time came into place, where it was observed that the loss of local control is around 1% per day when it is prolonged beyond 50 days. This was observed then only. Now, when you talk about it, we have come back to the same overall treatment time now based on the latest EMBRACE results, where it is shown that any prolongation over 49 days or 7 weeks leads to detriment in the local control, which has to be supplemented with higher doses of radiation. So these big five trials, what's important to when you analyze results is that you also need to see whether this group of patients actually completed the chemotherapy. So what is seen is that approximately 60 to 90% of the patients were able to complete 4 or more cycles of chemotherapy, which is the case across even today. So with all these major trials, and which were randomized controlled trials, the NCI issued an alert in 1999 saying that all these patients, the locally advanced cervical cancer patient, that is 1B to 4A, patients should receive concurrent chemoradiation. So then came in the question of the need of meta-analysis. So what the critics said was that there was where they said that the PSC trial had no survival benefit, and there were heterogeneous groups, and there were multiple heterogeneities observed in the multiple trials. So the critics felt that there was no need of meta-analysis. Nevertheless, a meta-analysis was done wherein 19 randomized controlled trials over 2 decades were taken for analysis. It was observed that cisplatin was the most common agent used, and it was seen that there is an absolute benefit of overall survival in the range of 12% and progression-free survival benefit of 16%. So the maximum benefit was seen in stage 1 to stage 2 patients. And this chemotherapy also had a significant benefit on local and distant recurrences, at the expense of grade 3 and grade 4 hematological toxicities and GI toxicities being more in the chemoradiation arm. So it has to be remembered that now maybe the GI toxicity profile will be less, including the toxicity profile, because of the use of conformal techniques at present, because at that era it was mainly cobalt based therapy. And also there have been inconsistent data on late toxicities. So they're divided into platinum versus non-platinum trials. And like you see here, the trials again which stood out were these big 5 trials. Again, when you look at this forest plot, you see that chemoradiation has a benefit irrespective of whether it's a platinum or a non-platinum, with a greater benefit when platinum is used. So they updated their review, which was published in the Cochrane. It is a Cochrane review. So the update includes 24 trials with approximately 5,000 patients. Again, here they concluded that CTRT improves the overall survival and PFS, whether or not cisplatin has been used, with the absolute benefits of 10% for overall survival and 13% for progression-free survival. The concurrent scheduling showed better results, with weekly scheduling being comparable to 3 weekly. And there is benefit both for local and distant failure rates. So the results, what was observed, the observations were that the results were better if concurrent chemoradiation was used, and if a platinum agent is included, and if hydroxyurea is not used. And weekly cisplatin is as good as 3 weekly cisplatin. So again, here there is significant heterogeneity, and acute toxicities were recorded only in 8 studies. And if you see, the 68% was represented by the early stages only. So then they concluded that these results may not be extrapolated to advanced disease. So this was they included all the trials. Now, what the Luca meta-analysis did was they included patients who received concurrent cisplatinum. And here again, what they saw that there was a significant benefit in the CT-RT arms, with a relative risk reduction, significant relative risk reduction, again, higher in the early stage groups. I will not go into details. So again, like I said, this benefit was seen more in patients with stage 1 and 2, maybe because the representation was higher. So now again, because the majority of the patients present in locally advanced stages with 2Bs and 3Bs all being more, even in the Western population during that time, there was a need for IPD meta-analysis because still there was no consensus to what regimen had to be used and which drug was the best drug and what doses have to be used. Like you've seen in the previous slides, that there have been multiple dosages used from 30, 40 milligram per meter square to 70 milligram meter square, with dosing schedules being different, and what combination would be of benefit, and if there is any specific subgroup which would be benefited for the use of concurrent chemoradiation, or any group in which the benefit is less, so as to avoid the chemotherapy to reduce the side effects. So this is the IPD analysis that was done. So what was 13 main randomized control trials were taken, and the conclusions are that concurrent chemoradiation improves both overall survival and disease-free survival. This will be commonly asked in your question in your exams also. So overall survival to the range of 6% and DFS to the range of 8% was seen. And the other RCTs that were evaluated were the RCTs for adjuvant chemotherapy, one of which was the Peters trial, in which there was an absolute improvement of 19% at 5 years. Like it's seen here, again, CTRT fares better even in the IPD meta-analysis. So it varies stage-wise. So when you look at all the outcomes, including overall survival, loco-regional disease-free survival, and metastasis-free survival, everywhere it is seen that chemotherapy plays a role. So it also was seen that the effect of chemoradiation did not differ in women defined by age, histology, tumor grade, and lymph node involvement. That means to say that it helps in all groups of patients. So when we talk about the stage-wise benefits, it is seen that the overall survival benefit for patients with stages 1B to 2A was in the range of 10%, and 2B was 7%, and there was a decline in this benefit in patients from stage 3 to stage 4B, which was only 3%. These were the various toxicity profiles that were available amongst the trials. So with this IPD meta-analysis with the use of stringent inclusive criteria, the most up-to-date and comprehensive summary effects of CTRT was available. And we also understood that chemotherapy had modest systemic benefit, and stage-wise benefit was analyzed, which was not done before because of the heterogeneous groups that studied in different trials. And there was significant benefit that was obtained with non-platinum agents too. Now, what was not resolved is that with the use of this combined modality, we still didn't have any data for late toxicities, and also there was no evidence to suggest that one treatment type or dose or schedule was better than the other. Again, which leads to confusion of what has to be used in clinics, and the benefit was less as compared to the previous meta-analysis, which happens in case of IPD analysis. And there is also insufficient data on quality of life, because at that time, quality of life studies were not very common. So with this, because in the IPD meta-analysis in the previous studies, like I told you before, the benefit of concurrent chemoradiation in advanced stages was less pronounced. So this is a randomized control trial from our country, from our institute, wherein it was hypothesized that there would be a benefit of 10% by adding chemotherapy for this group of patients. And mainly this was conceptualized because most of the patients who landed up in our clinics elsewhere also in our country at that time was 3Bs. Now there is a decrease in the number of 3B patients that we see in the clinics, but at that time, and now also to a large extent, it is dominated by this group. So wherein again patients were randomized to chemoradiation with cisplatin versus radiation only with the use of brachytherapy. So what was seen here is that the DFS, there was an 8% DFS benefit for patients who received chemoradiation in stage 3B. So this is one table that I got from the Embrace 2 protocol. So this is the retro Embrace, or these are the trials from the West wherein they have reported their outcomes prior to Embrace, before the use of image-guided adaptive brachytherapy. So what can be seen is that there is the clear, as compared to the Embrace, as compared to this retro Embrace, the Embrace group has achieved higher local control rates, especially with an improvement in stage 3 with the use of adaptive brachytherapy techniques, with also an improvement in the nodal control. But unfortunately, we do not have the survival outcomes as yet for the from the Embrace group, which then can be compared to the retro Embrace or our group of patients. So that concludes the evidence and the protocols for concurrent chemoradiation. So the take-home message is that as of now, patients, locally advanced cervical cancer patients, should be treated with the concurrent chemoradiation with cisplatin as the main agent if they are fit for chemotherapy, and weekly regimen is tolerated better, and an aim of at least reaching to 200 milligram per meter square is important. Now, when we talk about neoadjuvant chemotherapy, so the indications, the investigators and the clinicians have tried to increase the to have actually tried to increase the what would I say, they would want to aggressively treat these tumors so as to achieve better control rates, because what is disheartening from the clinician's side is that you treat patients aggressively and you do image-guided brachytherapy, but at the end of the day, they come back with higher rates of distant metastasis. So these are some of the questions posed by the investigators. So the indications of neoadjuvant chemotherapy in cervical cancer is mainly to downsize the tumor prior to surgery if it is an operable tumor. But then I'll talk about the evidence later. And this is another indication which does not have robust evidence, but is followed in the clinics, especially when patients have adjacent organ infiltration, mainly bladder infiltration or rectal infiltration, and there are bulky lymph nodes beyond more than 3 centimeters, which you feel will not respond to the tumoricidal doses that we give from radiation. These are some of the off-label indications that in which we give neoadjuvant chemotherapy at our institute. Like I said, there is no evidence for this, but these are the only indications as of now. Even for the first indication, I will tell you the evidence and I will let you know the take-home messages later. So NACT, again, it all started in the 90s. So what was seen is that when they used neoadjuvant chemotherapy, they were looking at complete responses and partial responses prior to radiation or prior to surgery. And again, what was observed is that the use of cisplatin actually did not result in dramatic response rates, and there were lower response rates. There were lower complete response rates. But again, it was thought that it was maybe because of the dosages and that patients did not receive 3 cycles of chemotherapy, which would lead to higher tumoricidal effect, wherein patients would receive only 2 cycles of chemotherapy because of their tolerance or various other factors. So these are some of the studies which made which led to the hypothesis that maybe neoadjuvant chemotherapy will downsize the tumor and it will increase the operability. This led to the EORTC trial, wherein patients were, but remember that this study was in the early stage patients, not really locally advanced. So it is 1B2 to 2B. So they wanted to address if patients have a response after neoadjuvant chemotherapy, if surgery could be done and radiation be done away. This is also because of the logistic issues that at that time the presence of radiotherapy centers or the expertise or the technology wasn't there, which is still the case in many of the LMICs and low middle income and the low income countries. So this is one of the approach that the investigators wanted to explore. They compared this neoadjuvant chemotherapy followed by surgery versus with patients who would receive standard treatment in the form of concurrent chemoradiation, and the endpoints were overall survival and progression-free survival. So what was observed in this study was that again there was no difference. There was no difference if in patients who received concurrent chemoradiation versus patients who received systemic chemotherapy followed by surgery. So what's important to understand is that patients who undergo neoadjuvant chemotherapy and then surgery, if at all there was a presence of risk factors such as positive margins or parametrial involvement, then these patients would again be subjected to radiation. So it is important to take note of the toxicities also with the use of so many regimens. So this is a busy slide. What you have to remember is that there is no difference between both the arms. It can be argued either wise also, because in areas where radiation therapy is not available, this option which is provided similar results as compared to CTRT can be used, and also that you can reserve radiation when it relapses, because the overall survival is not very different in this group of patients. So this around the same time, there was an institutional randomized control trial having similar patients trying to address the same question. So when we compare both the trials, it is seen that the baseline characteristics of patients and the tumor has been similar, except that almost all the patients had squamous cell carcinoma in the published study from our country. So here what you see is that again there is no difference in patients who there is no difference in the outcomes with respect to DFS and OS when you use NACT followed by surgery or CTRT. So so what I would like to say is that neoadjuvant chemotherapy stops here. So that even in the earlier stages, it is not shown superiority over chemoradiation, but can be used in view of logistics. But this cannot be extrapolated to the locally advanced cervical cancer patients with macroscopic nodal positivity. There is no evidence to use neoadjuvant chemotherapy. But like I said, in the clinics, when we are faced with difficult decision making in view of bladder infiltration and good performance status of the patient, then we would try to explore this option again to see whether these patients are chemosensitive or not, and whether, because that acts as a surrogate marker for radiation. And suppose patients do not respond to chemotherapy, then we would not aggressively treat these tumors. So another question which is important is that now that we've almost reached the plateau of local control rates in the range of 80 to 90% from 2B to 3B, what's important is that whether we can improve the survival or the outcomes for this group of patients by adding adjuvant chemotherapy. You can extrapolate maybe from nasopharynx also. Things have been tried in cervix also. So Outback is an important trial which was whose results were awaited, but unfortunately it has been a negative trial which has been included in this review too. So what are the conclusions of this review is that adjuvant chemotherapy again does not add to the improvement in outcomes in this group of patients. So now when we talk about extended field radiation, the indications of extended field radiation is the macroscopic paralytic lymph node, that is a pathological paralytic lymph node in the paralytic lymph node. And with the Embrace-2 protocol being in use for the past 3 to 4 years, they have given certain indications wherein the patients who have more than 3 pelvic lymph nodes, a higher propensity for para-aortic lymph nodal involvement. This is the group of patients whom you can consider lower para-aortic irradiation, that is the prophylactic EFRT. So this is the initial trial, the IFL or the RTOG 9001 that I mentioned. What's important to note here is that irrespective of whether it was chemo, radiation, or EFRT, the para-aortic failure rates have been similar. That means to say that patients who come back, they come back with distant metastasis with or without the involvement of para-aortic lymph nodes. So this is another trial during the same time that was done by Christine Heimeder in France. They also tried to evaluate the role of prophylactic para-aortic lymph nodes. So what was observed is that there was no difference in the local control, distant metastasis, and DFS. And the incidence of para-aortic lymph nodes and distant metastasis without tumor at the pelvic slides was higher in patients who were receiving pelvic RT only. But there was a higher GI complications rates in patients who receive para-aortic RT. So it is not recommended. They did not recommend routine EFRT or prophylactic EFRT for patients with cervical cancer. But patients who had a higher probability of being controlled locally, that means to say patients who have locally controllable disease with some nodal burden, those are the patients you have to consider for para-aortic nodal irradiation, even though there are GI side effects. So basically you have to look at the risk versus benefit ratios. So again, here they again try to evaluate the role of extended field radiation in the prophylactic setting. Again, this was negative, where the conclusions are that it is not recommended. So this is another group of patients. This is a very nice study. I'm sorry, it is not it's not visible properly. So what was done is extensive surgical staging can be done. So patients with pelvic lymph node positivity, like I said, patients in stage 3, if they have 45% of pelvic lymph nodal positivity, this group of patients will have para-aortic lymph nodal positivity in the range of 30%. So to identify this group of patients, what was done was surgical staging was done, para-aortic surgical staging was done. And suppose positive pathological nodes were identified in this staging, and further you give EFRT to this group of patients, they had better outcomes as compared to patients who did not receive EFRT. So these are multiple studies, because now, like I said, GI toxicity is very important. In addition, because concurrent chemoradiation is the standard of care, and we would give chemotherapy for this group of patients also, hematological toxicities also become important. And number of patients who can complete this form of therapy also becomes less. So it's important that we do conformal and IMRT techniques for this, for when you're planning for extended field radiation. So this was this is the EMBRACE-2 protocol that I've been talking about, where a risk-based strategy has been used for the nodal irradiation. If you think of head neck cancers, something like that is done here in this group. So like I said, patients with more than or equal to 3 pathological nodes by the radiological criteria or by staging, which is done in some part of Europe, and otherwise, if there is one or more than one pathological lymph node at the common iliac region, so it makes sense to treat the upper station. So that's when the para-aortic irradiation would come in. So these are the fields that are proposed and that is being used in the EMBRACE-2 protocol, and I think they've completed more than 150 patients. So the contouring, the problem that we face in the clinics is the contouring. So what we tried was validation of the nodal contouring that was done by Keenan group. We tried and we extrapolated that into our patients to see if at all we are covering them properly or not. So we saw that the Keenan guidelines fairly covers the group of lymph nodes that we would like to treat. Because there have been no contouring guidelines, parietic lymph nodal contouring guidelines for cervical cancer. What has been extrapolated was the Beriwal paper, wherein they had contoured for pancreatic nodes. But it is important for us to note that the lymph nodal distribution is different from that of the pancreatic cancer. So now, when we talk about pregnancy and cervical cancer, this is a common situation that we encounter in our clinics. So when you try and triage patients for treatment, or you would want to do a pregnancy preserving approach, or you do not a non-preserving approach, it all depends upon the stage of cancer, and also it depends upon the gestational week of the patient. So this is an important flow chart. You intently see this. So if it is a tumor less than 2 centimeters and the woman is in her less than 22 weeks of gestational weeks, so what's important is to do a pelvic lymph node dissection. You have to remember that as the gestational week increases, the lymph nodal yield decreases. So it is important to identify the gestational week. So you do a lymph nodal dissection, pelvic lymph nodal dissection, mainly to see whether it is a lymph node positive disease or a lymph node negative disease. Suppose it's a lymph node positive disease, then neoadjuvant chemotherapy is suggested and termination of pregnancy. If it is less, or termination of pregnancy is suggested. So less than 22 weeks, you want to push, then you give neoadjuvant chemotherapy, or you do a termination of pregnancy and treat the patient. Suppose it is negative, you can deter the treatment till delivery, or you can go ahead and do a simple trachelectomy at that time. So because these are early stages, and you know that lymph nodes are not involved. Like in the second slide, I said lymph nodes are the most important prognostic factor in cervical cancer. Suppose the woman is beyond 22nd week of gestation, then again, the options of neoadjuvant chemotherapy or deterring the treatment till delivery is done. Suppose it's a locally advanced cervical cancer. So this, if it is more than 2 centimeter, but still it's 1B1, we follow the same as that of 1B1, or less than 2 centimeter, 1A2. Suppose it is more than 1B2, again, gestational week should be seen. It has to be noted that there is no role of radiation during pregnancy. That's very important. You are going to give chemotherapy till the delivery or till the fetal maturation, and then do a hysterectomy, and then go ahead with the treatment. If that is not the case, then termination of pregnancy and radiation has to be considered. With this, I end my presentation. Please let me know if there are questions.
Thank you very much, Dr. Lavanya. Let me see if there is anything in the chat box. There are no questions as yet. So I welcome the participants and the listeners to put in questions in the chat box if they like. But ahead of that, while we wait for some questions, let's see. Let me just try and get a sense and review quickly the most important things that you have said. Now, we'll go to the first topic, which is what is the information base, the database on what is our database that we are trying to review the database on which we have made a decision for giving chemoradiotherapy. We accept that there is an NCI alert, which was based primarily on the 5 positive trials, but the only trial that was head-to-head, which was head-to-head comparison of radiotherapy with or without chemotherapy, which is what we practice today, was negative at that point in time.
Yes, it was negative. Yes.
Okay. Now, subsequently, and that's my question. We have looked then, we've also looked at some Indian data, and we have this huge data of roughly 800 patients of led by the Tata group, Professor Umesh Mahanshetty and team, and Professor Kasham Srivastav and team. It's an 8% difference in DFS where you give 50 gray plus brachytherapy, 40 plus midline block, and then brachytherapy with or without chemotherapy in adequate doses. 40 milligram a meter square would work out to be close
More
to
than
55 to 60 milligrams of cisplatin, assuming a 1.5 meter square patient. And that's stiff. I don't know. I reckon that not more than 2/3 of patients would be able to do 4 weeks of.
I showed that, sir. I didn't tell that, but approximately 70% received more than 4 cycles.
Okay, that's very heartening. That's a good number. That's a good figure, a good compliance. So now there's an 8% difference in DFS. Is there any chance at all we could know about the OS? I don't, if it's published, if it's not published.
It's not
published. Okay, fine. Okay.
Because
fine.
the attrition and loss to follow-up is so much in our country. So that was also one of the reasons that DFS was taken as an endpoint.
Perfect. Yes, we know that because at least outside of clinical trials at one point in time, at least in UP, in the shall we say, in the cell phone era, widely used, let's say for the last decade, it was better part of 50% loss to follow-ups. And within clinical trials, we were about 30%, 20%. Now with cell phones and, having multiple, keeping at least 3 cell numbers.
Patients, trying to track our patients.
Yeah, you track patients. You at least get a sense whether the patient is alive or not. True. And that's brought down the unknown rate to less than 5%, without doubt. This is at least what we see here. Okay, so that's as far as it goes, as far as the first topic goes. The second topic that we discussed today was the use of neoadjuvant chemotherapy. And I think you principally talked about the fact that if you have something that is likely to be a difficult surgery, when you talk of 1Bs, 1B and 2Bs. Now 2B, I think 2B proximal. In fact, we would probably not operate 2Bs.
Yes, sir. With our publication of NACT trial, and the EURTC trial also, now the standard of care is CTRT only for 1B and above.
Sure. So even if you had a tumor that was confined to the cervix, but more than 4 centimeters, which makes it, what is it, 1C now?
1B3.
1B3, right. Thank you. So even that,
we wouldn't operate.
You wouldn't touch.
No. The surgeons wouldn't operate because the Landonis update also, and also with the improvement in our RT techniques, they wouldn't operate.
Okay. So what then is the contemporary, in your view, if you can give a view, what is the contemporary use of neoadjuvant chemotherapy in the operable subgroup?
In the operable subgroup, no, we wouldn't. I mean, there are very few patients, maybe patients who have contraindications to radiotherapy. This is the only group that would undergo neoadjuvant chemotherapy.
And we believe this buys time before the patient can be set up for surgery because of waiting lists and inevitable waiting lists and other things. Now, the other thing is, I think that is common practice here. The radiotherapy wait lists are large, and as you would know in Tata Hospital as well, patients can't stay, they go back, and inevitably public health sector facilities are overburdened. And so we resort to giving 2 or 3 cycles of chemotherapy. I noticed one of your papers talking about 22% with 3 cycles and 4% CR rates with 2 cycles. Was this in stage 3B or was it in stage 2B?
No, those were in the initial stages, 1B to 2B. That was they were the initial studies which were trying to address the role of neoadjuvant chemotherapy for surgery. They are not the present studies.
Sure. So is there data on the use of chemotherapy before for 3Bs to tide over waiting periods? I am personally not aware.
No, there is no scientific evidence for that. No.
Okay.
Because the Outback trial has come as negative trial. So that was one trial which we were looking forward to. But having said that, I am not sure if the Westerners look at the similar profile that we see in our clinics. Because one indication where we give, and we've analyzed around 120 patients of our own with bladder infiltration, who come with 3 by 3 centimeter bladder infiltration, or with a 5 centimeter or 6 centimeter lymph node with no lung metastasis, wherein we surely know that these are the group of patients who would have systemic foci. So these are the group of patients where in a multidisciplinary team, including the patient and the medical oncologist and the radiation oncologist, takes a calculated call and goes ahead with it. But definitely not for wait times. You try and refer the patients out, but then that's not an indication for neoadjuvant chemo.
Right. So we accept that's a compulsion of our practice rather than evidence-based.
Yes, yes.
Right. We also are generally aware of the problems of accelerated repopulation. Those are theoretical, but currently we're just talking data. Okay. So we come to the third one, where you look at adjuvant chemotherapy after standard treatments, and you advise us there's no advantage. We don't follow that in any case. Now, we also heard your views on
because I said that because there is a Chinese study where in adenocarcinoma histology patients, there was an improvement in the outcomes in the form of overall survival, but then we do not practice that as yet.
All right, fine. Okay. And then finally, you've obviously talked of pregnancy and cervical cancer and given us a very useful algorithm. Incidentally, we had a talk just the other day on different facets of pregnancy and cervical cancer, and this really complements. Right, so let's go down to the question in the chat box, and I'll just read it out. If a patient is initially staged as 3B post-investigations, and then on simulation CT, we find gross pelvic external internal iliac nodes, comma. So what should we do? SIB only or prophylactic extended field radiotherapy as well? What's your response, please?
Okay. So like I said in my first slide, FIGO 2018 strongly recommends cross-sectional imaging. So if it shouldn't firstly be identified on simulation CT scan, it should have been identified on diagnostic CT scan. So now you find gross lymph nodes, macroscopic lymph nodes in the pelvis. So you're going to stage it as stage 3C1. That's the first thing we do. And then we look at the size of the lymph nodes and the location of the lymph nodes. Suppose there are lymph nodes, there are small lymph nodes of 1 to 2 centimeters, which are low lying, then we would not do prophylactic extended field radiation. Suppose there are bulky lymph nodes and there are more than 3, then we do prophylactic extended field radiation. Only the lower parietic lymph nodes, we are going ahead and treating them from the past 2 years based on the EMBRACE2 protocol, because it seems scientifically sound. And regarding your question of SIB, of simultaneous integrated boost versus sequential integrated boost, that depends upon the technique that you're using. Suppose you are using a 3D conformal technique, then you can go ahead with sequential boost. But you have to remember that the treatment time increases here, and you have to be really vigilant that you do not miss these nodes after external beam radiotherapy. Keep a note of it, and during your wait time to brachytherapy, try and start the sequential boost. But again, you have to keep a mental note of the dose that the patient would receive from brachytherapy, because external and internal iliac group of lymph nodes receive at least 3 to 4 gray. Suppose you have a facility for IMRT along with image guidance, then SIB is also a technique that can be used, which we commonly use in our setting. I hope that answers all the questions.
So now that you actually talked about IMRT in intact cervix, I believe there are concerns about IMRT in intact cervix.
Yes.
And so that's when you can do a SIB. Whereas if you did a conformal method, you would do a sequential boost.
True.
So
Yes.
what's your take then on this, on giving an IMRT and giving a SIB?
Like I said, if there is an IMRT, you should have image guidance because of the tumor of the organ motion that is notorious in cervical cancer. So only if you have an image guidance, then you can go ahead with IMRT with a properly placed protocols of your institute. Otherwise, you can go ahead with the conformal and a sequential boost.
The protocols you talk about are bladder filling. What do you do
Yes.
for rectal filling?
So
Or
for
what do you
the
do for rectal emptying? You have a
so,
rectal emptying and a bladder filling protocol. What exactly is the protocol?
yes, so for bladder filling, what we do is just make sure that the patient, when the patient lands up in your clinic, just assess the hydrational status of the patient there only, so that you improve the hydrational status of the patient till the time of simulation. And then at the time of simulation, what we do is we ask the patient to empty the bladder and then give them 750 ml of water, which they'll have to drink over a period of 15 minutes. And then we take a scan after 45 minutes. For rectal emptying, we do not really do much because it is difficult. It is difficult to maintain the same procedure during the entire course of radiation, because there are some centers where they use laxatives in the beginning. But then you have to understand that with the setting of small level toxicities in the third week, the use of laxatives is not possible, and also the constipation would have gone. So what we do is, this is the bladder filling protocol. The same is followed for treatment also. What's important in busy centers is to see to it that the patient goes into the treatment console around the same time. Otherwise, there have been accidents even in our institute with extreme bladder filling and accidents on the treatment console. As compared to rectum, what we see is that we do not accept a rectal diameter of more than 4 centimeters. So what we do is we do a check scan, because if it is more than 4 centimeters and you do not have daily image guidance, then there is a chance of geographical miss, because cervical motion is dependent on the rectal filling. What's important to understand is that cervical motion is dependent on rectal filling or emptying, and the uterine motion is dependent on the bladder filling.
Sure. So with the onset of cystitis, as a consequence of radiotherapy and proctitis in the third and fourth weeks and so on and so forth, particularly with concurrent chemotherapy as well, it is practically possible to maintain bladder fillings as bladder filling protocols as you state?
No, there will be changes. We have seen changes. So we reduce the time to take the patient to the console. That we understand as and when it happens. It definitely happens from third to fourth week. So we, instead of changing or making an adaptive plan, we take the patient slightly earlier because their bladder holding capacity becomes lesser.
Fine. So thank you very much for highlighting the challenges of IMRT, during radiotherapy. If there are no more questions, and I can't seem to see any more, so thank you very much indeed. This was well dissected. You provided us a lot of material, and so thank you, Dr. Lavanya, for taking time out.
Sir. Thank you so
thank
much.
you, our technical partners, and of course, Dr. Surbhi and Dr. Ashutosh and other colleagues here who are always there and actually set all this up for us. Thank you, everybody, and good night and have a nice weekend. Thank you very much, Dr. Lavanya, once again.
Thank you so much, sir.
Grateful.